All right. Well, good afternoon, everyone, and welcome to the January Grand Rounds from the West Virginia University CED. We appreciate your time and joining us, and we're honored to have our guest speaker here, Dr. Sujeong Park from Penn State at Harrisburg campus. And as you can see, she's already shared her desktop, but we're going to be talking about the rise, in particular, the illicit opioids, which, as you all know, definitely has affected West Virginia and larger portions of this region, but particularly the labor supply and disability claims. So, Dr. Park, we really appreciate your time and expertise with us today. I'm going to turn it over to you and let you get started. Thank you.
Thank you. Hi, everyone. Good to see you not in person, but in the virtual person. So my name is Sujeong Park, and I'm an assistant professor at Penn State Harrisburg. And this position is co-founded by a Social Science Research Institute at Penn State. So I actually, so today I'm going to talk about how the illicit opioid affecting labor supply, and also about SSDI, which you might be very familiar with. So before I go further, please let me ask you one question. How many of you are familiar of oxycodone reformulation? So I think maybe Zoom has a function to raise your hand. I don't know whether you're allowed to do that or not. So if you are familiar with that, please show your hands.
And you mean in terms of our work or whatever experience, if we're familiar with the opioid, right?
Yeah. Oh, cool. Okay, not a lot. Oh, a lot. So, but maybe you are familiar with the opioid epidemic, but maybe you don't. Maybe you are not familiar with oxycodone reformulation, which I'm going to talk about it a lot today. So let me explain it more in detail today. So this paper is published last year. That the co-author is David Powell at Rand Corporation, and we work on how the opioid had an impact on labor supply, and also we worked on how it had an impact on crime occurrence and other issues. So I'm going to talk about the background, so about the opioid and then what kind of policies have been implemented. And then also I'm going to introduce my research questions and then method, and I will share the outcomes, and then I will conclude. So everyone's like, know what opioid is, I guess. Opioid is kind of a painkiller, so it helps you treat pains. But sometimes it is because it is addictive, so maybe people are going to misuse it. So it can cause a lot of problem, and in the United States, it became a big issue. So in 2017, ex-President Trump declared a public health emergency because of prescription opioid issues. And 1.7 million people were suffered from the prescription opioid misuse. And according to CDC, the more than 130 people were dead because after overdosing of prescription opioid, which is a lot of people. So it became a big policy problem. So also it became a big health problems. So what I was thinking about when I learned about this is, I don't think this is going to be the only problem. I think opioid epidemic might have another impact on other issues. So I look into other literatures, and it seems like it has a lot of impact on labor market. So some people estimated economic loss, which is going to be $25 to $41 billion. And also there is a lot of increase in criminal costs because of the opioid issues, which some studies estimated is going to be around $3 to $7 billion. Also, there are several studies about how opioid epidemic had an impact on child welfare. It has increased the foster cares, and then also some people find child maltreatment increase, which is really sad. So today I'm going to talk about the labor part. So how opioid had an impact on labor, and also how it affected Social Security disability insurance. But before we go, I should explain more about the opioid crisis. So opioid crisis usually we assume it started around the 1999 with rise in prescription opioid overdose deaths. So, and you can see the purple lines, and then it has been increased since 1999. And then we can see there is another increase in orange line, which is heroin. The second wave started in the around 2010 or 2011 with a high with an increase in heroin overdose deaths. Nowadays, we are talking about third wave, which is started around the 2013, which is about the synthetic opioid overdose deaths. You can see the dark blue line, and then you can see there is a sharp increase in the overdose deaths because of the synthetic opioid. So this is what happened during the opioid crisis. A lot of people were dead because of that. And then federal government or state government tried to do something. So during the first wave, there was an approval for the abuse deterrent version of the oxycodone in 2010. So oxycodone is one of the most common prescription opioid. And then the FDA approved the abuse deterrent version. And then in 2010 August, Purdue pharmacies stopped distributing the original version of the oxycodone, and then they only distributed abuse deterrent version of oxycodone. And in the second and third wave, state level policy has been implemented, which is a PDMP, Prescription Drug Monitoring Program. And actually, PDMP has been implemented. It started around the 1900, but the modern version of the PDMP started around the 2012 from the Kentucky and then West Virginia. But today I'm going to talk more about the oxycodone reformulation rather than PDMPs. So oxycodone reformulation, you can see that these pictures. So original formulation is, so how people misuse oxycodone is usually if you want to get high or if you want to get faster. In fact, what you're going to do is you are going to crush the pill into a powder. And then you are going to snort it or inject it, or you are going to use in other way with a powder. But with the new formulation, which from the 2010, if you try to crush the oxycodone, it is going to be a gummy gel instead of a powder. And then it is not going to be easy to misuse it anymore because you cannot snort it or you cannot inject it. So that is how people try to respond to the prescription opioid crisis. So people thought if we make harder to misuse oxycodone pills, people will stop using it or misuse it. So that was the what we expect. Actually, many studies provided some evidence that this behavioral restriction decreases some prescription opioid deaths. However, always when you implement a policy, there is unintended consequences. So one study in 2018, some researchers tried to evaluate the effect of the oxycodone reformulation. So the policy tried to limit the access to prescription opioid misuse. However, what we expect is a decrease in opioid misuse. But actually what happened is there was an increased demand for substitution, which is heroin. Heroin and opioid are almost the same drugs. So, but heroin is not quality controlled because you are going to get it from the street. So which means it is going to be more dangerous. So there was an increase in heroin overdose deaths, which was higher than decrease in prescription opioid overdose deaths reductions. So that is what happened with the oxycodone formulation in health perspective. And then we are going back to the broader effect. So I was thinking, so in that case, if the oxycodone reformulation had an impact of the overdose deaths, which is kind of extreme case, what about the labor market, or what about the criminal justice, and what about the child welfare? So these are my dissertation. So these 3 papers, but today I'm just going to talk about the labor market today. So that was the background, but do you have any questions so far? Because I usually think everyone, because I read a lot about the oxycodone reformulation of opioid things, and sometimes I used to assume people knows about that already, but sometimes it's not. I will give it 5 seconds, and then if you don't have any questions, I will proceed it. Okay. So I want to evaluate how oxycodone reformulation had an impact on labor market, and also maybe also in social security disability insurance program. And first of all, the labor market outcomes, and then I found several studies about how opioid crisis had an impact on labor market outcomes. So some people said if there is a prescription opioid availability, it usually brings more use in prescription opioid, and they usually lower the labor force participation or decline they show the decline in labor force. But however, another study said rescheduling of the hydrocodone, which is another type of opioid, it reduced the medical access to hydrocodone, and then actually improved the labor force participation. And the other studies tried to evaluate the PDMP implementation, and then they found that because of the PDMP implementation, people moved to the heroin or other synthetic opioid, and then it gave led to reduction to the in employment. So there are some mixed results about how opioid crisis had an impact on labor market, but in overall, people think it gave a harmful effect on labor market. And now we are going to talk about Social Security disability insurance. So this is a really big federal program, which is 4% of federal budget. And actually, people might going to be confused because substance use disorder, it cannot be the only, if you have a substance use disorder only you cannot get the SSDI. It is not enough. So because substance use disorder, if you with only this condition, you are not qualified for the Social Security disability insurance. So if you want to have receive the Social Security disability insurance, you should have another medical condition, which is not a substance use disorder. So it sounds like, oh, so if substance use disorder shouldn't be associated with SSDI beneficiaries, but it is not. Actually, among SSDI beneficiaries, there is a higher substance use disorder rate. So if you receive SSDI, it means you are more likely to have a substance use disorder. So how opioid how oxycodone formulation might have an impact on the SSDI application rates, because opioid misuse or heroin misuse is not going to guarantee you get the SSDI. But oxycodone reformulation will increase access to heroin and fentanyl. It means that it will have a harmful effect on the labor ability, which might you want to, even though you have another condition, you didn't have to, maybe you didn't need to apply for the SSDI before, But now because you have a heroin misuse symptom or something, you want to, because you cannot work anymore. In that case, you want to apply for the SSDI. So that will be the possible mechanism. Also, some people said, hey, if you did have maybe oxycodone reformulation, they use opioid misuse initiation, maybe so it is going to have a beneficial outcomes on labor ability, so which can be true. But and also there is another mechanism about how the maybe oxycodone reformulation policy has expanded the illicit drug market, and then it is going to increase the crime, and which is harmful for population health, and then it might have an impact on the economic conditions. So there are several possible mechanisms, but I'm going to focus on the first mechanism. So oxycodone formulation would increase access to heroin and fentanyl, or demand to the heroin and fentanyl, and then it would cause harmful effect on labor ability, and then it will lead to the increase in SSDI applications. So this is my hypothesis and research questions. So my research question is, did the oxycodone reformulation in 2010 increase the SSDI applications, and also whether it decreased the labor participations? So my hypothesis is going to be, after oxycodone reformulation in 2010, states with higher opioid misuse rate before 2010 would experience a larger increase in SSDI applications and decrease in labor participations. So I'm going to explain what kind of research design I used to answer this question. But before I go for the method section, if you have any questions, this is the time. Okay, no. So let me talk about the data first. So for the labor outcomes, we use several data sets, so we can confirm whether we are not depending on one specific data set. So we use the Bureau of Economic Analysis, current employment statistics, and the American Community Survey. And for the SSDI, we got data from the Social Security Administration. And then for the drug use, I use the National Survey on Drug Use and Health. And then I use the current population survey and marijuana policy database and Medicare CR data to get some control variables. And this is my empirical approach. So I am going to use the different rate oxycodone misuse rate for the oxycodone reformulation. So let's assume one state has a high oxycodone misuse rate in 2005, 2006, 2007, and 2008, 9 or 10. That state, after the oxycodone reformulation, there will be a lot of people who cannot use the oxycodone to misuse it after the oxycodone reformulation. It means there will be higher transition to heroin due to the reformulation. It means the states with high oxycodone misuse rates will be more affected by higher illicit drug use. If the state doesn't have any person who has who misuse oxycodone before the oxycodone reformulation, even though after the oxycodone reformulation, that state will not going to experience any change because they didn't. That state didn't have any person who misuse oxycodone. But this is not true. We have at least one people at each state. So what I did is we used the oxycodone misuse rate and then interacted with the ER variables and then compare that before the oxycodone reformulation and then after the oxycodone reformulation, and then how the oxycodone misuse rate had an impact on our outcome variables. So this is my equation. So my outcome variable is going to be labor supply and then disability outcomes in state level and then each year. So this is a year state level outcome. And then oxy rate this one is the state level of variables. So I'm going to give each state I assigned oxycodone misuse rate for each state, which is between the 2004 and 2009. So which is before the reformulation. And this delta is going to be coefficient for the oxycodone misuse rate. And also I use the pain liver rate, which is fixed pain liver misuse rate. So I can kind of separate the oxycodone misuse rate and then other pain liver misuse rate, because oxycodone reformulation will have an impact only for the oxycodone misuse, not the pain reliever. So I don't want to see any effect of the delta, any difference in delta before and after the reformulation. And I also include a lot of control variables, and that is my equation. So just one more thing, the reference level for the data is going to 2009. So which is just 1 year before the oxycodone reformulation. Okay, so let me give you show some outcome analysis result. Here, this is the labor market outcomes. So this is from the Bureau of Economic Analysis, and then this red line is the 2009, which is my reference level. So each point show the delta here, and then as this 2009, I put delta as 0, so as a reference level. And then what I expect is the impact of the oxycodone misuse rate isn't going to be different before the reformulation, because before the reformulation, 2009, 2008, there is no exogenous shock on the drug use. However, after the reformulation, I expect the delta each point is going to be negative. It means if the state had a higher oxycodone misuse rate, they will experience a lower per capita employment. So as you can see, 2009, 2010, the effect was pretty nothing, but as time goes by, you can see that there is a lot of decrease in labor participation in high oxycodone misuse states. That is also true for the other outcome variables, such as the per capita employee compensations and percentage of work. So this is the labor market outcomes. And also I did some heterogeneous effects of that policy. And then I was able to find that this effect was bigger, larger on males, and then white, and then lower educated people, and then younger people who are under 50 years old. So that was the labor market outcomes, and then this is the here is. So male has more showed a more reduced labor participation, and then white showed a less reduced labor participation. And what I'm going to show is going to be the Social Security disability application. So first, panel A show the application per capita. So you can see before there is no difference between the 2009. So this is a reference level. And then there is no difference in delta coefficient. So it means even there is, however, after the reformulation, you can see the increase in coefficient. It means if the states have a higher oxycodone misuse rate before the reformulation, they will experience a higher Social Security disability applications. So even though the opioid misuse or substance use disorder is not qualify for applying for the disability SSDI, we assume maybe they have another condition already, and then because of the opioid misuse, they experience maybe harder economic conditions, and then it may lead them to apply for the SSDI. That was our interpretation for these outcomes. And then let me introduce the second outcome variable, which is a favorable determination per capita. So problem is the beneficiary information from the SSA. The application date and that determination date is not going to be the same, right? If I apply for the SSDI, sometimes it is going to be really quick to get the result, but sometimes it's going to be really take a lot of time to get my determination. So sometimes I heard even it takes some years. So we asked the SSA to could you give us the information so about the application, so based on the application years, and then how they how you determined whether you are going to provide the SSDI or not. So this so for this panel, this one is means each year. So it is the application, and then for that year, and then also it shows the determination based on the application year. So you can see there is an increase in 2010 and compared to 2009. So after the oxycodone reformulation, we also we were able to see there was a favorable determination for the Social Security disability applications. And for the beneficiary per capita, so this one is not benchmarked to the application years. So for when you see this figure, you should be more careful with interpretation, because it means, so if you are in the 2011, it means maybe you apply for the SSDI in 2009 before the oxycodone formulation. So it doesn't guarantee the application happened in the same year with a beneficiary year. Okay. So also I did the same analysis with by diagnostic conditions. So which diagnostic condition might has more increase in SSDI due to the oxycodone formulation. So we chose 4 conditions because they are the they share the largest portion of the applications, and then these are the Social Security disability beneficiary due to the mental disorders, and you can see the increase in the number of beneficiaries after the oxycodone formulations in states with high oxycodone misuse rate. You can see see the same parents in other diagnosis groups. However, they are less statistically significant compared to the previous labor market or application rate. So we also checked with the different functional forms, and also we use the biotic prediction, so which we can predict local economic conditions. We try to control the economic conditions, and also we try to use different functional forms. So we want to make sure this is not because of the specific functional forms, or not. So we checked the checklist, and then it seems like our result is not from the economic shock, and also it shows a consistent result across the different functional forms. So my conclusion is effect of the oxycodone reformulation on labor market participation was negative, and then also it increased disability insurance applications. And I'm going to work on this area in near future. So I am going to continue to work on the unintended or intended consequences of drug policies, and try to find the demand and supply side of policy and interventions, because the oxycodone reformulation is a kind of supply side intervention. And then it seems like it may works for some people, but in overall, it read a lot of overdose deaths, and then also it shows the negative effect on the labor market. So I want to also find another effective interventions which also focus on demand side. So this is the end of my presentation, and so this is my contact information. If you have any questions, please let me know. And then because I think I'm pretty nervous. I try. Yeah. I don't know. I don't know how to finish this. I didn't expect this a lot of people actually, so I was a little bit nervous. So, and then if I'm nervous, I talk too quickly and then miss some important points. So maybe if you have any questions, and Sujeong, you didn't explain this part, and I have more questions about it, and then please let me know. Hey.
No, Dr. Park, I thought you did really well. It's a very complicated subject matter, and thought you went through it very well. In terms of your audience, there are many on here who probably served individuals who, when we saw that change in the labor market, but the increase in disability rates, started to serve them. So I wonder if people saw a difference in the services that were needed at around that time. You know, we saw different people seeking those services. So obviously, if they had been using those particular drugs, maybe they needed different things. Did anyone notice that about that time? Any anecdotal effects? Yeah, stimulus checks. We've also had a switch from OxyContin to heroin in some portions of ours, and that's why I was asking earlier, like if that switch, like you were saying, would have changed the labor and the needs either. So it's good that you're looking at interventions next and services provided.
So a lot of people ask me about the question, like, so it means you're saying we shouldn't do the abuse current oxycodone pill or something. So I thought, no, it is good for people who is going to initiate the opioid. But if you are just give the abuse deterrent version for the people who are already misuse it, but it's going to bring some effect. So what I was thinking is maybe we can do the two-track approach. One, we just provide the same reformulation pill for the people who already used it, but for the people who are going to initiate the oxycodone later, we can give the new formulation so we can prevent the initiation. So that was the my thought for the oxycodone reformulation policy. Okay. So there are a lot of comments. Yeah, about the COVID, I would like to check with the COVID how COVID had an impact on the opioid use parents, because um what what I was thinking is maybe people are going to even harder to get heroin now, so because they need to go outside to get a pill. Now I don't know how they are going to get their pills. So it's going to be my next question about how the COVID had an impact on opioid use. And hey, population.
Excuse me, I have a question for you. In your presentation, you mentioned synthetic drugs, and obviously that's a very major concern today. When you can go in, the kids can go into head shops and buy synthetic cocaine or just about anything they want. I mean, I know a lot of states have banned those, but as soon as they banned it, something else comes in and takes its place. How much impact does that have with your study overall?
So let me make sure I understand your question clearly. So you're asking about how the reformulation had an impact on synthetic opioid, or?
Yes.
Yeah. So previous study done mine, so done by other people. So Abby and David, Dr. Alpert and Powell, they shows that there was an increase in heroin overdose deaths due to the oxycodone reformulation. And then I believe David Powell also did another study saying long impact of the oxycodone reformulation on synthetic opioid overdose deaths. So they show that because of the not because of the, I don't know how to say it, but due to the opioid oxycodone reformulation, there was a long-term impact on the synthetic opioids overdose deaths too. So it is not only for the heroin, and also for the other synthetic opioid use, because I think that people who get heroin, and then maybe that heroin, they are going to have more access to the other drugs, the other synthetic opioids too. So yeah, I don't know how much had an impact on the synthetic opioid overdose deaths, but there are several studies saying that opioid overdose death, oxycodone reformulation had an impact on synthetic opioid. And then also I would like to mention about the PDMP, which is the prescription drug monitoring program. This is the state level, and then most access PDMP is that you should access to the state database to before prescribe the certain type of drugs. So it makes people harder to get prescription opioid and other drugs. And then I read some papers. Also, this most access PDMP had a negative impact on health, because people, if you are going to if you cannot get the prescription opioid, you are not just going to stop. You are going to look for other substitution. And then this most access PDMP had also similar effect on the overdose deaths. So, and then also I read a paper saying this PDMP also had a impact on synthetic opioid overdose deaths. So not only the oxycodone reformulation, another supply side of the policy, which is the PDMP, it has an impact on the overdose deaths too. So which I believe West Virginia introduced this policy in 2012. So yeah, but I think the problem is, I think, the timing. If we adopted this kind of PDMP earlier, it will be more effective. But now, because we had a lot of people already misuse opioid, that now when we try to stop them, they are going to find another substitutions. So yeah, that is the problem with the supply side issues. I don't know whether I answered your question or not, but
Yes,
hopefully,
ma'am, you
yes.
did. And thank
Yeah.
you very much.
Thank you.
I used to work with kids, and I have several of my kids that are now brain dead because they were buying synthetic drugs at the head shops because it was cheap and they got addicted to it. And I mean, it permanently damaged them.
Yeah, it is really sad.
But yes, you answered my
Yep.
question, and I really appreciate you taking the time to give clarification on that.
Thank you. Is there anything I forgot to mention? I always forgot something I would love to talk, but
I think a lot of the chat people, I mean, there's so many examples of people who have different experiences where they're seeing your research play out in real life. So, I mean, again, and then I know you teach at 3, so we'll transition to that, but it's really interesting, and you see the comments made earlier that you combined the opioid crisis with the labor market. I agree with the earlier comments. I've never seen those two things paired with one another to really get that bigger view of that impact. So please share any of your future work. We'll be watching for future studies that you do. You're so close to us in terms of region that it's definitely pertinent to us. So
yeah, that would be great. So it is less relevant to the disability issues, but I am working on submitting my paper, which is about opioid, the oxycodone formulation and crime occurrence, because I saw the people are more likely to be a victim if they are trying to get illicit drug from the street. So yeah, once I get accepted, I will share my work later.
that'd be great. Thank you.
Yeah. Thank you.
All right, with that, we'll close out. I appreciate everyone attending, and Dr. Park, again, I appreciate you sharing us your experience and study with us. Have a great afternoon. This has been recorded, so please share that information. And Dr. Park, have a good class.
Thank you.
As well. Thanks, everyone.